Our last speaker, but clearly a very, very important topic on immunologic therapy will be Mike Atkins. Mike left the Harvard system about a year and a half ago, and is now Deputy Director of Georgetown-Lombardi Comprehensive Cancer Center. I've heard him give a talk on this topic before. It was outstanding, which is why we have Mike here today.
Thanks, Lee. It's I'm an ECOG member working at an Alliance institution, so it's probably appropriate that I'm giving this talk at SWOG. Also, coming from DC, which is now a ghost town, although my patients and retired friends tell me that golf courses are overcrowded. So I'm going to talk about immunotherapy. These are some of my disclosures. I'm going to give a little bit of a background in advances in tumor immunology, mention some checkpoint inhibitors, but I'm really going to focus on the PD-1 pathway and try to use it as a model for identifying key translational questions that need to be addressed in immunotherapy and could be considered in the context of clinical trials such as PD-1 versus PD-L1, what appropriate combination should be used, how do we think about biomarkers, in what setting should we use these agents, what tumor types should we treat. So this is data from Craig Slingloff, and there's data, this is from melanoma, but there's similar data in other tumors which suggest that about a quarter of tumors might have a dense immune infiltrate, and the higher the degree of immune infiltrate, the better those patients do, either by themselves or in response to specific therapies, and that's particularly true if those are CD8 cells. And that's led people in the tumor immunology field to hypothesize that there are two different types of tumors. Those that are non-inflamed, which may have high expression of vascular markers, macrophages, fibroblasts, and which are not very sensitive to immune therapy. And those that are inflamed, which have high levels of innate immune signals, chemokines to bring in T cells, but they also have a lot of immunoregulatory components which tend to keep the immune system in check. And one of the problems we realized we were in with our nonspecific cytokine-based immunotherapies is we tended to activate these regulators processes, including T regulatory cells, in most patients more than we did the effector cells. So one approach to getting around that was taken first by the NCI surgery branch and now other institutions, was to take the T cells out of the tumor, grow them up remote from those immunosuppressive environment, and then give them back in high doses to hopefully overcome those immunosuppressive effects. But many of us felt that was labor-intensive, complex, and wouldn't it be great if we could just inhibit some of those factors inside the tumor and allow the immune cells that are there to actually function. And that's where being able to inhibit PD-L1 and other checkpoints with antibodies has really been a game changer. So in contrast to CTLA-4 blockade, which you're probably all familiar with, which tends to reactivate the immune system in the periphery at the antigen-presenting cell in an earlier stage, and therefore have a lot of immune-related toxicities. The promise of reactivating the PD-1, PD-L1 pathway is that you can do it selectively where PD-L1 is expressed, which is inside the tumor, and therefore have a higher therapeutic index by having your treatment work essentially in the tumor microenvironment. And so recognizing this and the fact that hitting that target is a druggable target with antibodies, a number of companies have jumped into this field to try to develop either inhibitors of PD-1 or its ligand PD-L1. And these are a variety of different companies which have a variety of different agents that are being studied in various phases. The study that was the first one and where we have the most data about the most tumors was the multi-dose 300-patient phase 1 trial with BMS's molecule nivolumab in patients with melanoma, renal cancer, non-small cell lung cancer, colorectal cancer, and castrate-resistant prostate cancer. And in this study, which was published in New England Journal last year, there were responses in about 30% of patients with melanoma and kidney cancer in about 20% of patients with non-small cell lung cancer. And of the 65 patients with those 3 diseases in a total of 306 overall patients enrolled in the study, we can see that the responses, as shown here by these black circles, happened relatively quickly, almost half within the first 8 weeks. Over 2/3 are lasting more than a year, and about half are ongoing at the time this data was presented, and many of these have persisted off treatment, as shown here by these red bars with the arrows after it, with 70% of these responses being maintained once treatment has stopped. These are median response durations, which are impressive considering these were all heavily pretreated patients for non-small cell lung cancer, melanoma, and kidney cancer. And that ignores the fact that there were about 5% of patients, 13 out of the 270 with these diseases, that had actual unconventional responses where there was either new lesion or growth of existing lesions before they actually exhibited a response, as shown here. And the overall survivals are shown on this slide, which, once again, considering this is a heavily pretreated patient population, are pretty impressive for each of these diseases and have justified the 6 ongoing phase 3 trials of nivolumab in patients with these 3 cancers that have been launched, not to mention the trials that have been launched with the variety of other compounds that were shown on that earlier slide. And the toxicity is relatively mild. You can see the grade 3-4 toxicities are much different than what we have seen with cytokines or even with ipilimumab, with those happening in the 1 to at most 5% range or so. So I'm going to focus on questions that need to be addressed and give some insight onto some of those answers. So the first question is, should we prefer PD-1 versus PD-L1 blockade? So they're not the same because each component has either different receptors that it binds to or different ligands that it binds. So a PD-1 blockade will block binding of PD-1 to both PD-L1 and PD-L2, and there are some tumors that express only PD-L2, as we've seen looking in the kidney cancer spore with antibodies for PD-L2 at our kidney cancer database. While PD-L1 will leave PD-L2 unblocked but bind the interaction between PD-L1 and B7H1, which may or may not be favorable. So in looking at this and from observations, some of the data would suggest that the PD-1 blockers may be more active. The dose at which they're maximally active appears to be lower. For the BMS compounds, the activity was higher with the anti-PD-1 than their anti-PD-L1, but it's unclear whether this is really true because they haven't been compared head-to-head. And if they are better, is this because it's a more accessible target, having PD-1 on the surface of immune cells, which are either circulating or at the surface of the tumor, while PD-L1 is on the tumor cells, which may be harder for the antibodies to get to? Are these just better antibodies? Or is blocking PD-L2 important? It also appears that the anti-PD-L1s may be less toxic, and that could be just an artifact of the antibodies not working as well, or that keeping PD-L2 unblocked might be important in, for example, preventing pneumonitis, which is a major toxicity seen with the anti-PD-1s, with 3% of patients experiencing serious side effects. So this needs to be addressed. It can only be addressed with head-to-head comparisons. How do we enhance the efficacy of PD-1 blockade? What do we combine these agents with? So you could combine it with T-cell agonists like a cytokine or CD137 antibody that could drive the immune system while you're taking the brakes off selectively. You also could combine it with another checkpoint inhibitor, for example, a blocker of CTLA-4, given that those immune cells may contain more than one checkpoint on their surface. Or you could combine it with tumor-specific therapy. From my experience with biochemotherapy during the years in treating melanoma, I would be reluctant to try to just non-specifically combine this with cytotoxic chemotherapies that may inhibit the same type of immune reactions that you're trying to stimulate, even though that may have some advantage from a regulatory standpoint. It'd be much better if you could think of a way of getting these drugs to the first line without having to combine it with the existing first-line therapy. As an example of what can happen when you combine two checkpoint inhibitors is this data from ASCO that was published in the New England Journal by Jed Walchuk, looking at the combination of IPI and nivolumab, where you can see, in contrast to the activity of the single agents, rapid, dramatic decreases in tumor burden in over half the patients. I was at the American College of Surgery on Monday giving a similar talk, and I called this almost a surgical-like response. And you can see that there's a lot of significant disease regression, and considering that almost all of these responses are durable, if we could just fill in the rest of this area, we might actually be done in treating melanoma. Here's an example of a response with a large pelvic mass that in 12 weeks is completely gone. I suspect Lee would be happy with that result from a surgical standpoint. So not only do we need to decide what should we combine with in a particular tumor, but which is the best of the particular class of agents, and how do we identify that? Do we analyze baseline biomarkers in the tumor, or do we look, as we have done with other molecules, at escape mechanisms and try to target those escape mechanisms with the hope of trying to make the treatment work better? So that brings us into the discussion of biomarkers. Can we identify the patients most likely to benefit, and what is the optimal biomarker? Well, it looked like there was a clue from the initial nivolumab data where it suggested that if you didn't have PD-L1 expressed by the tumor, you were unlikely to respond to anti-PD-1 therapy. While the response rate was higher, all the responders were in the PD-L1 positive patients. Unfortunately, that does not prove to be the case, and there's a lot of issues with PD-L1 just choosing it as a biomarker, and they're listed here. First of all, the assays are technically difficult, they're imperfect, and the results may be different depending on the antibody or assay that's being used. You're looking at, for many of these assays, 5% expression, and tumors are very heterogeneous, particularly the primary tumors, and this is an inducible protein, and therefore there can be sampling errors. In addition, we're often looking at the primary but treating the metastasis, and we've done some studies in our kidney cancer data set to show that they're not always concordant. Further, PD-L2 could be a dominant factor in some tumors, as I've mentioned, and as the data I'll show you points out, it may be completely different answer when you're dealing with combination trials. So just to point out, there are plenty of responses in PD-L1 negative tumors. This is data from nivolumab. This is PD-L1 positive on top and PD-L1 negative, and a lot of tumor shrinkage here. So other questions related to biomarker. Which antibody to use? Do you measure it on the tumor or the immune cells, or both? Genentech has their assay on immune cells. What cutoff parameters? If you use a 1% cutoff, more tumors are positive, but the response rates are higher. If you use a 5% cutoff, their response rates are higher, but you miss half the responders. Which samples to use, primary versus metastases. And once again, if you look at the Ipi-Nivo combination, there's no evidence that PD-L1 expression predicts for response in that small data set. So that needs to be looked at more carefully. Other issues with PD-L1 as a biomarker is why don't all PD-L1 positive tumors respond? Well, it could be that PD-L1 is expressed constitutively related to an oncogene, and there's some data to suggest that it may be activated by the PI3 kinase pathway. In that case, it might be a setting where there's no immune infiltration. Or it might be that other checkpoints are being expressed at the same time and you need to use combination therapy. So that might suggest that immune infiltration might be a better predictor of responsiveness. But what immune parameter? Something like a CD8 to Treg ratio, interferon gamma expression, chemokine expression. The thing that I like the most is chemokine expression. Before I get to that, this is data that suggests that in melanoma, if you TIL are necessary but not sufficient for PD-L1 expression. But we don't know whether this is true in other tumor types where it may be more likely that PD-L1 is upregulated via an oncogene. And then there's this whole group of tumors, even in melanoma, that have immune cell infiltration but no PD-L1 expression. And are these the PD-L1 negative responders? Certainly something that could be asked. So one thing that I like to intrigued by is this work that was done at Moffitt by Jim Muley and Vern Sondek's group that looked at non-lymph node melanoma metastases and identified a 12 chemokine signature that was associated with a favorable outcome. And these chemokines were associated with these small ectopic lymph node structures that were present inside these tumors, something that might be poised, you could think, to maybe destroy the tumor here, would the checkpoints be eliminated. And so maybe that is something that one could use. But before I get to that and try to focus on that, I just want to give an example of a trial that we're doing in the kidney cancer spore to try to address some of these concerns. Is PD-L1 expression influenced by prior systemic therapy predictive of benefit for that, for another therapy that might be compared to? And is some other biomarker better? Is PD-1 blockade better applied in the treatment naive or the resistant setting? And what are the mechanisms of resistance to PD-1, PD-L1 pathway blockade? Are they the key to rational combination therapy, particularly if another checkpoint is involved? So we've designed a trial where patients are have a baseline biopsy, then they're randomized to a VEGF receptor TKI or a PD-1 antibody. At time of resistance, they get another biopsy, and then they're crossed over to the other therapy. And this will allow us to see what the effect of a particular biomarker is on response to the control treatment as well as PD-1 therapy, whether the biomarker changes in the resistant setting versus the upfront setting, and whether the activity is different for PD-1 blockade in the resistant setting versus the primary setting. What tumors are best to treat? Well, another way of looking at the data from PD-L1 expression from the nivolumab trial is to look at the percentage of the various tumor types that were positive. You can see that there were no positivities in colorectal cancer or prostate cancer. So one would have said, let's treat these tumors rather than identifying which tumors to treat. So what data is there out there about PD-L1 expression? So this is multiple cancers, old data talking about B7H1 or PD-L1 expression. But I remind you that this is using antibodies that are nothing like the antibodies that we're currently using, and some of these might be false positives. So we need to redo this type of analysis on fresh tumors or using current antibodies. But another approach is to use that same chemokine assay from Muley and try to identify tumors that at high levels of those nodal infiltrates, or that chemokine signature, which in addition to melanoma include cervical cancer and some head and neck cancers and maybe bladder cancer and sarcoma. And so this might help us decide which tumors to treat first. How do we best use biomarkers? So I think they're best used to identify disease types to treat. And right now those are tumors that are PD-L1 and or PD-L2 positive with some sort of immune infiltrate. Those lacking an oncogenic driver, those where PD-L1 expression is associated with no benefit with conventional therapy, so that we can compare PD-L1 blockade with conventional therapy and look at the more beneficial effect of the PD-L1 blockade, and to try to obtain fresh biopsies prior to treatment for exploratory rather than selection or stratification purposes. So why are some tumors with immune infiltrates not responsive? Could it be the expression of other immunoinhibitory molecules or the wrong immune cells? So here's a list of other immunoinhibitory molecules that could be blocked and could be contributing to T-cell exhaustion. LAG3 and TIM3 are two that there are antibodies for that are going into clinical trials. Finally, can one turn a non-inflamed tumor into an inflamed tumor with other treatment, either radiation, chemotherapy, vaccine, molecularly targeted therapy? And if so, how do we coordinate and sequence these therapies? Well, in melanoma, there's data to suggest that giving Vemurafenib can increase antigen expression and immune cell infiltration into tumors. So we've used this data to do a serial biopsy study in patients to try to understand both the timing and the function of that immune infiltrate. And here are 4 sequential biopsies at baseline, week 1, week 2, and week 4 from a patient getting Vemurafenib, where you can see these immune cells just sitting here on the surface at baseline, and then infiltrating the tumor within a week and forming these little lymph node type nests within 2 weeks, and then sort of being dispersed again by 4 weeks. So we've taken these cells out, we're going to study to see what they express, how active they are, and this might suggest that maybe you could take a tumor that's largely uninflamed and turn it into an inflamed tumor with this type of approach. And then one more area, adjuvant treatment, and these are great drugs to not just move to the first line, but to the adjuvant setting, but we need to know whether they'll work in the setting where there are only microscopic tumor deposits, because you might need to have T cells in the tumor microenvironment for the adjuvant treatment to work. So should we do adjuvant or neoadjuvant treatment? So these are some of the future directions in which we're pursuing with immunotherapy: activity relative to standard therapies, prospective study of optimal sequence relative to standard therapies, trying to get these drugs to the first line, refining biomarkers, studying various combinations, understanding mechanisms of resistance, identifying other therapeutically relevant checkpoints, adjuvant versus neoadjuvant therapy, and try and expand the utility to other diseases. And the hope is that when we do these studies, some of these will be done in the cooperative group, because they'll need to be, and they'll be able to add to it translational research objectives that will help to answer some of the questions that I've mentioned. Thank you very much.